Let's begin with smallpox. So, as we know, the smallpox is globally eradicated, and the causative agent of smallpox is variola virus belonging to Poxviridae family. It has double-stranded DNA, and I want you to remember certain historical details, okay, for the purposes of MCQs. So, in 1967, WHO began a worldwide campaign to eradicate smallpox. Alright, that is in 1967. Now, forward to 24th May 1975. That is when the last known case of smallpox in India occurred. Right? Okay. Again, fast forward to July 1975, India was declared smallpox free. Okay. Now again, April 1977, the eradication of smallpox was confirmed. That is in India, right? In May 1980, the global eradication of smallpox was confirmed by WHO. I hope that is clear. Now, for the clinical features, there is always high-grade fever, right? And there is headache and backache, and this the fever will be greater than or equal to 38.3 degrees Celsius. This will be 2 to 4 days before the onset of rash. Now, what kind of rash? It is a maculopapular rash. Now, how is its distribution? The distribution is it starts on the face and then it spreads to the trunk and the legs. Alright? So, it does affect the face, it affects the palms, it affects the soles. So its lesions appear at the same stage of development on any given part of the body, and no alternative diagnosis explaining the illness, and there should be diagnosis by laboratory confirmation. Okay, so smallpox eradication surveillance, that is, despite the absence of smallpox, surveillance rumors, right, continues in order to sustain public confidence in the eradication of disease. So that is because why? What are we saying here? So smallpox virus has not been completely destroyed. Stocks are still there in research centers. So there is surveillance. Alright, so that is all about smallpox. Next is chickenpox. Now, what is the agent of chickenpox? It is the varicella zoster virus, which is also called as human herpes virus 3. Alright, now, what are the agent factors? Now, what is the source of infection? The source is a case of chickenpox, right? Now, the virus occurs in the oropharyngeal secretions and the lesions of the skin and the mucus and the mucosa, right? So, rarely is the source of infection a patient with herpes zoster. Okay, so usually it is a case of chickenpox, that is the source of infection, right? So, there is primary infection, that is what causes primary infection causes chickenpox, and recovery can be followed by a latent infection. So that is when this virus it causes a latent infection in the cranial nerve, sensory ganglia, and spinal dorsal root ganglia. So this is after decades. So after decades without clinical manifestations, there is that is known as herpes zoster, and this occurs in about 10 to 30% of the individuals. Alright, so this is a very painful condition, right? Now, so we discussed the source, we discussed about the latent infection which occurs in 10 to 30% of the individuals. Now, what is the infectivity? That is the period of communicability of patients with varicella. That is, if you get varicella, how long can it be spread to another person? So that is 1 to 2 days before the appearance of rash, right? So you got this rash. So here it is you have vesicles, right? So this rash you got, and this before 1 to 2 days before the appearance of this rash, and 4 to 5 days thereafter. That is, after the rash is gone, 4 to 5 days after that also you remain infective. Alright. Now, the virus tends to die out before the pustular stage. Alright. Now, the scabs, that is not infective. The scabs are not infective. But the vesicles that are formed, the vesicular fluid in the vesicles, that is what is infective. Got that? Infectivity is clear, right? Now, next point, that is the secondary attack rate. What is secondary attack rate and what is second attack rate? So, second attack rate means the second time the disease is occurring, right? That is a second attack. No, I'm sorry, not second attack rate. Second attack means the second time the disease is occurring in the individual. So that is rare, right? Once you get chickenpox, there is lifelong immunity. I will be talking about that in a few minutes. So secondary attack rate is different, right? We learned that secondary attack rate means, so a person got the disease and now the number of the people who will get the disease from the primary case, that will constitute the secondary attack rate. So that is around 85 to 90%. Alright. Now, herpes zoster is approximately 20% as infectious as chickenpox, and in susceptible people, contact with herpes zoster rash will cause varicella, not herpes zoster. Alright. Okay. So age and factors have been covered. I hope that is clear. Next, we are moving on to host factors. So the reason I'm in a hurry is that because it is exam time and I do not want to create a lag. That is why I am rushing through the topics. Yeah, you can adjust the speed according to your convenience. Now, the age is usually, you see this in school going children, like less than 10 years of age, right? That is the age in which you see chickenpox primarily, right? Few persons, in few people you can see it in adulthood, right? Now, immunity. So as I said earlier, there is lifelong immunity, that is IgG antibodies. It gives protection against varicella. Alright. So next is pregnancy. So in pregnancy there is a risk of congenital varicella syndrome. So that is, infection during pregnancy will present a risk for the fetus, leading to congenital varicella syndrome. And this occurs in like very small percentage of children born to mothers who become infected, and note this, that is during the first 20 weeks of gestation. During the first 20 weeks of gestation. Infants whose mothers had chickenpox during pregnancy have a higher risk of developing what else? Herpes zoster in the first years of life. Right? So, remember, the age is early school going children. There is lifelong immunity. There is a chance of reactivation, as I said earlier, that is presence is herpes zoster, which is a very painful condition. In pregnancy, it leads to congenital, the risk, if it is in the first 20 weeks of gestation, there is risk of the baby developing congenital varicella syndrome. Now, next is the environmental factors. Chickenpox shows a seasonal trend, that is, its peak incidence is in the winter and spring, that is from January to April. Alright, and this virus is heat labile. It does not survive more than a few hours, maximum for 1 or 2 days it survives in the external environment, and it is also inactivated easily. Now, transmission is by droplet nuclei, that is, direct transmission is by droplet nuclei or from placenta. Transplacental transmission can occur, right? So by the placental barrier, and it can infect the fetus. As we said earlier, recall the condition is congenital varicella. Now, that is direct transmission. Indirect transmission can also occur, that is via air. Alright, so just recall what are the diseases which are transmitted by airborne transmission. That is a few examples, yeah, influenza, measles, yes, tuberculosis, COVID, chickenpox. Alright, These are the infections. Now just remember it using some code, right? IMTCC. Use that code, okay? IMTCC. This is the infections which is transmitted by airborne transmission. Now incubation period is usually 14 to 16 days. It can go from 10 to 21 days. So if an average is asked, okay, 15 days, right? Now clinical features, there is a pre-eruptive stage and there is an eruptive stage, all right? So there can be a mild illness, okay, there is a few scattered lesions, or it can be a severe febrile illness, all right? And in adults it's like more severe. Now what the pre-eruptive stage we're going to start off with. Now this is the before the eruption, right? Pre-eruptive. So mild or moderate fever will be there will be back pain, there will be shivering and malaise, okay? Note the fever is mild or moderate and it lasts for about 24 hours. We're talking about children here. Now in adults it can last for 2 to 3 days before the rash comes out. It is more severe, that's what I said earlier, more severe in adults, the pre-eruptive stage, okay? Now eruptive stage is eruptive, that is rash comes. So in children the rash is often the first sign, so it comes on the day the fever starts, and the distinctive feature of the rash is its distribution and its rapid evolution. So that is and pleomorphism, all right? So and fever, that so we will look on to the distribution, that is centripetal, that is it is symmetrical, the rash is symmetrical and it first appears on the trunk, that is in the center, okay? So, where it is abundant. Now it is abundant in the trunk, but in the face and arms and legs it is less abundant. The mucosal surfaces will be involved, all right? The palms and soles are usually not affected. In smallpox, palms and soles are affected, right? Now rapid evolution, the rash will advance quickly, that is it is going through stages of what are the stages? 4 stages, remember: macule, papule, vesicle, scab, all right? Macule, papule, vesicle and scab. So vesicles are like the first to attract attention. So the vesicular fluid, as we said earlier, is infective also. It looks like dew drops on the skin. These vesicles may form crust without going through the pustular stage also, all right? Now scabs will begin 4 to 7 days after the rash appears. Scabs are not infective, all right? So remember, the infective period, as I said earlier, is 1 to 2 days before the rash and 4 to 5 days after the onset of the rash, not after the rash is gone, I made, okay? Yeah, after the onset of the 4 to 5 days after the onset of the rash. Till that it is infective, the person is infective. Now pleomorphism, as we said earlier, we talked about pleomorphism. We said that in smallpox there is no pleomorphism, right? There is no pleomorphism. Here there is pleomorphism, that is all stages of the rash, papule, vesicle, crust may be seen simultaneously. In smallpox, if it is vesicles, only vesicles, but here it is not like that, everything will be seen simultaneously, all right? This is due to the rash appearing in successive crops for 4 to 5 days in the same area. Now fever does not run high, but it shows exacerbations with every fresh crop of the eruption. Now what is the difference between smallpox and chickenpox? Can be asked as a short question, not like a very common question, but yeah. Incubation for smallpox around 12 days. In chickenpox it is around, we said it can go from 10 to 21 days, but usually it is around 14 to 16. We said an average of 15 days, right? Yeah, you can write 14 to 16 days. Now prodromal symptoms are severe in smallpox and usually mild in chickenpox, all right? Distribution of rash is centrifugal in smallpox. Palms and soles are frequently affected. Axilla is usually free, and rash is predominant on the extensor surfaces and the bony prominences. And in chickenpox it is centripetal. You saw the rash was more in the trunk, the density was more in the trunk, and its density was less in the arms, and right? Yeah. Now palms and soles are seldom affected, that is, it is affected, and axilla is also affected, and rashes on the flexor surfaces as opposed to the extensor surfaces in smallpox. What is the characteristic of this rash? Rash is deep seated, where in smallpox, and it is superficial in chickenpox. The vesicles are multilocular in smallpox, it is unilocular in chickenpox. One stage of the rash may be seen at one time in smallpox, no pleomorphism, and there is no area of inflammation around the vesicles. In chickenpox, the rash is pleomorphic and there is an area of inflammation around the vesicles. Okay, fever will subside with the appearance of rash in smallpox, may rise again in the pustular stage, right? That is in the secondary rise of fever. Okay, and in chickenpox, temperature rises with every fresh crop of rash. Okay, complications. So usually chickenpox is a mild disease. It is self-limiting and mortality is less than 1% in uncomplicated cases. So but in some immunocompromised people and in normal children and adults also it may occur. The complications may occur such as hemorrhage, there is varicella hemorrhagical, pneumonia can occur, encephalitis can occur, acute cerebral ataxia can occur, and Rey syndrome, that is an acute encephalopathy, right, which is associated with fatty degeneration of the viscera, especially liver. Okay, so this is the complications, but Rey syndrome and all, it is very rare. Now in pregnancy, if there is varicella, it can cause congenital varicella syndrome. I told this 2 times already. Now that can result in defects such as cutaneous scars, atrophied limbs, microcephaly, low birth weight, microphthalmia, chorioretinitis, deafness, right? All these conditions can be caused. So if to pregnant mother, if varicella develops within 5 days of after delivery, the newborn is at risk of disseminated disease and should receive varicella zoster immunoglobulin, right? Also, this virus is associated with acute retinal necrosis and such in increased frequency, right? Progressive outer retinal necrosis can also occur among AIDS patients. Okay, they are immunocompromised. So this can occur in AIDS patients. Next is lab diagnosis. So you can do it by detecting the varicella zoster virus DNA using PCR, polymerase chain reaction, or you can isolate this in cell culture, right? You can isolate this virus from the fluid or the crust or saliva, etc. You can also do a serological screening of serum, right? You can look for the IgG antibodies, right? Now IgM antibody detection is less sensitive than PCR. It is not the method of choice. Now the control measures will be notification. We will notify we will notify the authorities, and we will isolate the people, the cases for 6 days after the onset of rash, and disinfection is done, disinfection of the articles soiled by nose and throat discharges, okay, to prevent the spread. We can give varicella zoster immunoglobulin. So when is this given? It is given when when there are susceptible exposed individuals, right? It is given to it is given to susceptible persons receiving who are in immunosuppressed state. Okay, it is given to pregnant mothers to prevent congenital varicella syndrome in the child. Okay, pregnant female who is exposed to varicella, this is given, right? And in severe immunocompromised state like HIV positive, and the person is symptomatic for HIV, or the person is under long-term steroid therapy, all right, or the infants born to varicella infected mothers. To these people we give what? Varicella zoster immunoglobulin, right? It is for the prevention of chickenpox, and it is given within 72 hours of exposure as per your textbook. Alright, now what is the dose which is given? So this is given by intramuscular injection in a dose of 12.5 units per kg body weight, up to a maximum of 625 units, and in if there is prolonged exposure, there is a repeat dose in 3 weeks. Now that is about varicella zoster immunoglobulin. So next is vaccine. So vaccine is a live attenuated vaccine. So this virus vaccine, it is safe. Alright, now what is the dose? It is 0.5 milliliter by subcutaneous injection, right? It is given so ideally the age of administration is 12 to 18 months, all right, and it can be given to all children until 12 years, right? So ideally we give in 12 to 18 months of children, 12 to 18 months of age, all right. Now so that is it. Then A booster dose is given at 4 to 6 years. So first we give it at 12 to 18 months and then we give the booster. So ideal age, as I said earlier, 12 to 18 months. Now till 12 years you can give it. Okay, now after 13 years, if the adult is exposed to varicella, you can give this vaccine. Okay, now the gap between the two doses, like if you're giving 2 doses, the gap between the 2 doses, it is it is like 1 to 3 months in children, that is less than 12 years, it is 1 to 3 months, and it is 4 or 6 weeks for adolescents and adults, right? 13 years of age and older, it is 4 to 6 weeks, 4 to 6 or 4 to 8 weeks, right? Yeah. So that is the vaccine schedule. Alright, to summarize, it is a subcutaneous injection. Now 0.5 ml, 12 to 18 months in children, right? 4 to 6 years is the booster dose. Okay, above 13 years, if there is exposure, you can give the vaccine, but then above 13 years means you have to give a gap. Okay, 2 dose gap should be 4 to 8 weeks between the doses. Alright, next is and then if it is below 12 years, 1 to 3 months gap should be there between the 2 doses. Alright, okay, next is post exposure prophylaxis. So post exposure prophylaxis, so if the person does not have any contraindication, the vaccine can be administered as soon as possible within 5 days after exposure to the rash. Alright, so that is a post exposure prophylaxis, and the contraindications are, you can guess it, right? It is a live vaccine we are giving. Within 5 days we are giving it, the live vaccine. So because it's live, so you cannot give it in severe immunocompromised state, you cannot give it in pregnancy, and you cannot give it in any case of anaphylaxis. If the person is allergic to it, you cannot give it. So that is it.